Good evening, everyone. Thank you all for joining this exciting side event at the 79th World Health Assembly on preventing childhood obesity and type 2 diabetes. We're going to hear from a really amazing cast of experts at every level of making action. I think I tried to count in my past, one of my pastimes is birding, and so you try to judge the number of birds. So I think that there are about 80 of us in the room here physically present, which is quite an extraordinary turnout. And online, we are about 530. So really a huge turnout for this important event. So I'd like to thank the World Diabetes Foundation for having invited me to moderate this panel. But I'll start with a confession that I feel very out of my depth. I've worked for 40 years in public health nutrition and really focused on undernutrition, so fighting wasting, stunting, deficiencies in essential nutrients. But I've also have to begrudgingly come to terms with the fact we're also facing a crisis of overweight and obesity. And to share a few things that have brought me to this realization, some of our own work at Helen Keller International, where I work, we were looking at diets of children 6 to 23 months, that critical period when breast milk alone is not enough. They need very nutrient-dense diets. And it's shocking across the countries we would do the research how much that period is being flooded with unhealthy ultra-processed foods, which is bad in its own right and is crowding out nutritious foods. And then also very personally, I live in Dakar, Senegal. I live with my grandson Enzo, who's now 2.5, and just seeing how difficult it can be. I mean, all of the foods that he's exposed to that are very cheap, very affordable, very easy to package, very attractive. When he's does his mom, does his granddad refuse them? It's really difficult because the food environment is really stacked up against us. And then, as probably everyone knows, and Katrin, I suspect you'll share some of these data with us when I call you, we're facing a turning point where for the first time on record from the data we have, there are actually as many or more children facing overweight and obesity as underweight, which is really tragic. Now, to me, that does not mean there's less urgency of addressing what I've dedicated my life to, of undernutrition. It just means there's also urgency to make sure we are addressing overweight and obesity. And to my mind, and this is where, to me, it's going to be an incredibly educational experience moderating these panels, comes together really around food, healthy food, nutritious food, helps address both the undernutrition and the overweight and obesity agenda. So to start us off, we're very pleased to have a global expert from next door, just across the street, Katrin Engelhardt, who is a scientist at the World Health Organization, Department of Nutrition and Food Safety. And Katrin, I'll call you up to the podium. Please welcome Katrin.
Thank you so much. Thanks so much for the invitation to join you at this really important point. We are indeed at a turning point, as we've just heard. So it's my pleasure to address you, dear delegates and distinguished guests and partners and colleagues to this event organized by really important civil society organizations. Childhood obesity is really one of the strongest drivers and risk factors for type 2 diabetes. And we're really seeing a concerning shift because type 2 diabetes is increasingly occurring earlier in life with significant implications for our health systems, for our societies, and for our economies. Today, Sean said, I'll talk about a couple of statistics. I don't have many, but I think this is a really staggering number. Today, over 1 billion people are living with obesity globally, including 188 million children and adolescents. And at the same time, diabetes continues to rise. And it rises rapidly, with projections suggesting hundreds of millions more people affected by 2050 if current trends continue. So this isn't only a growing public health problem and a public health challenge, it's a deeply unequal one. Some of you might have seen the data in the recent Nature article published, which is analysis from the NCD Risk Factor Collaboration, which highlight this clear divergence. Many high-income countries, in those childhood obesity rates have stabilized or are plateauing, But in contrast, in low and middle income countries, rates are increasing, and they're accelerating in many cases. We still have 100 countries where obesity continues to rise, and the problem is the fastest rise is in countries that actually have health systems that have the least capacity to respond, and that compounds the burden of early onset of obesity, earlier onset of type 2 diabetes, and also longer exposure to the complications across the life course, bringing even more burden to the health system. So we're facing an equity and a health crisis in this situation. So talking about these two issues of diabetes and childhood obesity together is really, really important. So these trends are not only driven by individual behavior alone, as I'm sure everyone in this room knows, they really reflect systematic and structural determinants. Across many settings, healthy diets remain unaffordable and inaccessible. Implementation of food and nutrition policies also remains uneven. WHO hosts a global database of implementation on food and nutrition actions, GIFNA, and if you go to that database, you can see that implementation of policies that protect children are unequally implemented, with low and middle income countries implementing far less of these policies, these protective policies. So as a result, vulnerable populations continue to be disproportionately exposed to unhealthy food environments, and they bear a growing share of the diabetes burden as well. Food marketing remains one of the most powerful drivers shaping unhealthy dietary behaviors. Despite the resolution, we're at the World Health Assembly, but some of you might remember the resolution from 2010 on marketing of foods and non-alcoholic beverages to children. But despite that resolution, marketing continues to be primarily for unhealthy foods, for foods that are high in unhealthy fats and sugars and sodium, that are ultra-processed. And marketing continues to influence children's food preferences, their consumption patterns, their purchase behaviors. The problem is marketing has become even more aggressive. For those of you who have children, know the problem of the use of the digital space that's practically glued to their hands. Marketing has become more aggressive, is predominantly digital, is targeted, personalized, and continuous. It's often embedded seamlessly into entertainment and social media interactions of children. Marketing exposure operates below children's conscious awareness, which is why it's so important to protect children. It influences behavior cumulatively. So many of you have preferred brands when you eat, select clothes, etc. You don't really know why you have these preferences, but you do. Marketing can be a strong result of that, or a strong reason for that. So children are not adequately protected through voluntary industry measures, which is why WHO in 2023 issued guidelines on marketing restrictions, which recommend that policies be mandatory to increase their effectiveness. The unhealthy food environments children are growing up in contribute to childhood obesity and diabetes. So they're a risk factor, but they also undermine children's right to health, children's right to adequate nutrition, the right to protection from harmful commercial practices. So children are exposed to environments that systematically favor unhealthy decisions. Addressing this imbalance is a core responsibility of governments, institutions, and partners, including those in the room. And I think we all know what works and how to counter this imbalance. And I'm sure everyone in the room is working hard to advance one or more of the recommended policies by WHO, but they're always worth repeating, and I think we should repeat them until every country in the world is implementing them to better protect children and populations from commercial determinants of health. So we have the WHO Best Buys, the Stop Obesity Acceleration Plan, which highlights a set of scalable interventions. And they include those that create healthy food environments from the beginning of life. We often forget children at the beginning of life, but that's where the food preferences really start. So we need to start with looking at protection, promotion, and support of breastfeeding, implementation of the code of marketing of breast milk substitutes, and also appropriate complementary feeding practices. And here, an important point, which is sometimes forgotten. At the moment, Codex Alimentarius is working on standards for complementary foods. So we as a public health community need to do as much as we can to ensure that in these discussions that are taking place at Codex to develop new food standards, the health of our children is protected through these standards and that they're strong enough to protect the health of children. Other population measures include unhealthy food marketing, restrictions, front-of-pack labeling, fiscal policies, and also creating healthy school food environments, which I think you'll hear about. Schools remain a platform for nutrition and for physical activity. And of course, we need to create safe environments in which children can lead physically active lives, which are conducive to physical activity. And that's also not a given. You said you live in Dakar in Senegal. It's not as easy for a child to go for a run or a walk or a bike to school than it is here in Geneva. So we need to work towards creating safe environments. In parallel to creating healthy and safe environments in which children can thrive, we need to strengthen the health system's response. I hope some of you on the panel are also going to talk about the health system's response. Through the WHO Acceleration Plan, which makes it quite unique actually, the response to obesity and diabetes is increasingly integrated into health systems across the life course. And key elements of that plan include, for example, embedding prevention, screening, counseling into primary care. So we mustn't forget that. It's not just about the food environment. We're establishing chronic care pathways for obesity and related conditions, including type 2 diabetes. And we need to link population-level prevention with clinical management and long-term follow-up. There will be a WHO guideline forthcoming on the management of childhood obesity, which will also provide health systems responses. So important progress on all fronts is actually already on the way, which is good. For example, under the Stop Obesity Acceleration Plan, 34 countries representing 1.3 billion people are advancing implementation. The emphasis is really shifting from strategy to commitment, from delivery, scale-up, and impact. And countries are adapting intervention packages to their national capacities, which is important, combining food environment policies, health system responses, and cross-sectoral engagement. So I'm looking forward to these examples. Just 3 key messages maybe to conclude. First, childhood obesity and type 2 diabetes are deeply interconnected, and they require a life course approach. The rising burden is driven by structural determinants, particularly unhealthy food environments that require action through regulatory measures. And sustainable progress really depends on integrating prevention and care and strengthening health systems. I know it's not about health promotion, but I do think for those of us who've been in this area long enough, when we listen to those key messages, they might remind us of the vision of the Ottawa Charter for Health Promotion, which is now 40 years on, and it reminds us that health is shaped by policy, by environments, and by collective action. So my sincere thanks to the organizers and to civil society and partners whose leadership and commitments are really essential to driving this agenda forward. Thank you very much.
Thank you so much, Catherine, for sharing that overview with us. I would like to now call on a representative from one of our member states, Dr. Ronald Afana, who's the Chief Executive Officer for Health from the Kingdom of Tonga. And if you would step up to the podium, sir, and thank you so much for joining us and sharing your wisdom with us.
Excellencies, distinguished guests, ladies and gentlemen, it's a great pleasure and honor for me to provide some reflections on behalf of the Minister of Health for Tonga, who has other obligations at the plenary at the WHA meeting. Pacific Island countries carry one of the world's heaviest obesity burdens across all age group and both sexes. Trends over recent decades have shown no meaningful improvement. Instead, the epidemic continues to worsen, and the Kingdom of Tonga is no exception. The Pacific has strong legislative frameworks, a clear NCD roadmap, and an accountability mechanism, the MANA dashboard, to track each country's progress against national, regional, and global WHO targets. According to the latest MANA dashboard update, Tonga has made encouraging progress in implementing several WHO best buys, interventions, and policy options, including taxes on unhealthy foods and sugar-sweetened beverages, and regulations on foods sold in schools. In 2023, at the Pacific Health Ministers meeting in Tonga, one of the key areas for discussion was the drivers of obesity in Pacific communities and identifying new solutions with a particular focus on children and young people and shaping a healthier future. Moreover, Tonga was selected at the Global Nutrition Summit in 2021 as one of only 2 countries in the Western Pacific region as a global frontrunner for obesity, identifying Tonga as a country driving success and a progress across the 5 focus areas: nutrition and universal health coverage, food systems, transformation, vulnerable situations, accountability, and financing. However, non-communicable diseases, or NCDs, remain a national priority for Tonga due to the substantial burden they pose on our communities and the ongoing challenges they present for our development and national progress towards achieving our SDG commitments. This is a global issue, and the worldwide pandemic of obesity brought about by unhealthy diet and physical inactivity has increased the threat of some NCDs, especially type 2 diabetes and metabolic syndromes. Similarly, in our context, the changes in food environment where people are moving away from traditional diets to rely much on imported processed foods, fueled by an environment that allows unhealthy foods more readily available and affordable than healthy foods, are major contributing factors to the skyrocketing rates of obesity and NCD in Tonga. Comparison of the Tonga 2012 and 2017 STEP surveys showed that most of the risk factors increased, especially those related to overweight and obesity. Overweight and obesity rose from 90.7% to 94.7%, while obesity alone increased from 67.6% to 79.4% in the adult population. And according to the WHO UNICEF report in 2019, a similar trend noticed in childhood obesity, where more than half of children and adolescents between the ages of 5 and 19 years old were overweight or obese, accounting for 58.9% in 2019, an increase from around 20% from the 1990s. A lot of works, including policy and legislation development to address the social and commercial determinants of these changes, physical measures and community-based programs throughout healthy setting approaches in addressing NCD risk factors have been going for years in Tonga, but the action taken does not seem to match the magnitude of the problem. We are not on track to meeting our SDG targets. The increase of obesity and NCD has been driven by a combination of personal behavior and environmental factors, and reducing the burden of NCD in Tonga may require a transformation that should focus on the principles of behavior change. We need strategies that encourage and enable people to adopt healthier behavior across all aspects of their lives. Develop critical knowledge and tools that focus on triggers for long-term behavior change that lead to healthier lifestyles for the prevention of NCDs. The learning of healthy behavioral habits is vital during childhood and teenage years, and studies have found that lifestyle learned in childhood are much likelier to stay with a person until adulthood. If healthy eating habits and physical activity are family and school priority, They will provide children with strong foundation for a lifetime of health. The Tonga Ministry of Health, in response to this required transformation, has established a partnership called Apiako Ma'alahi, which is the health promoting schools with the Ministry of Education, to strengthen the concept of promoting health in school children through building its capacity to function as a healthy setting for learning and living and working. It allows members of the school community, including parents and the surrounding community, to work together to provide students and staff with integrated positive experience and structures that promote and protect children's health. The three priority areas of focus are diet and physical activity, water, sanitation and hygiene, which is WASH, and mental health and well-being. Health Promoting School, or Apiako Ma'alahi, views health holistically, addressing the physical, social, cultural, mental, intellectual, and spiritual dimensions of health comprehensively. It is in line with the Healthy Island Framework vision of the Pacific, where children are nurtured in health and mind. It provides a safer and more inclusive environment for students to engage in their learning. There are real benefits that can be reaped. Good health supports successful learning. Successful learning supports health. They are inseparable. In fact, there is a strong correlation between good health and academic achievement. I'm nearly finished, and thank you for your attention. Recognizing that access to nutritious food is essential for health and learning, the government of Tonga supports providing free breakfast to all primary school and middle school students from age 5 to 14. The benefits include improving children's dietary quality by reducing reliance on unhealthy processed foods, enhancing concentration and academic performance, reducing health inequalities, and establishing healthy eating habits early to protect against obesity and type 2 diabetes. Free school meals also relieve financial pressure on families, while creating a daily opportunity to reinforce healthy eating in the school setting. Obesity and NCD impact the health of children and adolescents, a development period when the associated unhealthy behaviors are mostly adopted. They therefore represent periods of opportunity for NCD control. The culture of fast food, big-sized portions, and increasingly inactive pastimes have resulted in an increased rate of childhood obesity and related health problems. If we do not address the problem early, obesity among children may put them at a high risk for developing NCDs later in adult life. Our school students are at the impressionable age, so they must be guided and motivated to move away from undesirable lifestyle habits through an enabling environment that makes healthy choices the easy choices. To conclude, the Healthy Promoting School program has widely adopted in Tonga and has been successful catalyst in creating health enabling environments. Through Health Promoting School, our aged people can develop their full potential and to achieve health and well-being for a healthier Tonga. But this can only happen if both ministries, the Ministry of Education, Health, together with whole of government, in collaboration with all our stakeholders. Malo aupito, and thank you very much for your attention.
Thank you so much, Dr. Fuana. I really appreciate your staring the problem boldly in the face and really analyzing what needs to be done. I think that's the beginning of the political leadership that's needed. That's an incredibly powerful country example, and I think we have a panel that's going to share 3 exciting country perspectives from Cameroon, from Mexico, and from Cambodia. And so if I could call up the first round of panelists. I will keep this seat for myself. And And a brief update, we're even more popular. We're now at 680 people online, so yeah. Clearly this resonates broadly. So I'm very pleased to have, we'll have a next panel to come. So starting with Professor Eugene Sobgui, who's the Director of Healthcare Organization and Technology at the Ministry of Public Health of Cameroon and a senior diabetes researcher. Thank you for coming with us today.
Thank you.
I hope to go to Cameroon next month, so hopefully I'll see you there. And then, personally, a hero of mine, Simon Baccarat, who is of the World Obesity Federation, and I think he has a day job at the Institute of Public Health, and has been one of the first people to really fight the fight to get sugar-sweetened beverage taxes. And so I think he'll share some of these stories with us. And then from the Kingdom of Wonder, the Kingdom of Cambodia, Ms. Hun Judria, who's the Vice Chair of the School Health Research and Innovation Bureau of the Department of School Health and Ministry of Education, Youth and Sport in the Kingdom of Cambodia. Thanks so much. And I had the great pleasure of actually visiting one of those programs that's supported by the World Diabetes Foundation and with Helen Keller International. It's really exciting. I think I'll share those experiences. So I'm going to start, we're going to pose a question to each of them, and we'll come back and do another round of questions. I can take it. I can try to take it. Yeah, okay. Thank you. So, Professor Eugene, from the Ministry of Public Health perspective, what does it take to turn national policies on nutrition, obesity, and diabetes prevention into real change at the community level, including in schools and health facilities? And hopefully your microphone will work.
Yeah, I hope so. Yes, it works. Thank you very much, and thank you very much for inviting me. And also, I thank the audience, those here in the room and those who are online. Yes, many low and middle income countries, and Africa and Cameroon, my country, are facing what we call the double burden of malnutrition. I will even say the triple burden of malnutrition, with obesity that is increasing while we've not yet finished with the agenda of undernutrition, with micronutrient deficiencies and undernutrition per se. So we have wasting and stunting alongside overweight and obesity in children in our countries. Therefore, the policies should take into account those two factors at the same time. And policy alone are not enough. It has to translate into action. And in order to translate into action, we need proper ownership by the population and by the right population. And obesity especially, it's not something that starts the day you see it. It starts long before. It starts in children, it starts even in utero, before birth. And these are the points where you actually need to a strong intervention. And a wonderful platform for intervention is actually schools. In countries like mine, where you have above 80% of adolescents who are actually going regularly to school, even in security compromised region, children are still going to school. School is really the perfect platform if you have to target adolescence, because adolescence is really a period where you have this plasticity of compartmental plasticity, and where also you have a great influence. Adolescents receive influence from their peers, so they influence their peers, they influence the family, so it's really a proper moment, it's a proper target. Since they are almost all found in schools, schools are the ideal environment to act on, because school actually, in schools you have all what it takes to build obesity and also to unbuild obesity. You can work on knowledge, you can work on enablers in the environment, healthy choices, to work on access to good food. With our research institute, RSD Institute, with the funding from the World Diabetes Foundation, we have actually worked together with the Ministry of Health and the Ministry of Secondary Education to build a co-constructed intervention that, that actually targets those adolescents. So we believe that it has to be integrated at primary care level, integrated in schools. It has to be co-constructed for proper ownership in order for the policies to actually become actions and sustainable with sustainable results. That's what I will say. And with a cascade of this intervention in the whole country, we've been able to see results in terms of people asking for more. We were surprised, for example, we started by saying, okay, we should reduce availability of ultra-processed food and sugary beverages in schools, and we're surprised that the children themselves and the schools asked for, first of all, a day without sugar. So we've been able to implement a Thursday without sugar-free Thursdays in schools in Cameroon. And there are some schools that are actually aiming for a school-free, sugar-free school. And it's actually what was constructed by the adolescents and their teachers that is being turned into policy, because the Ministry of Secondary Education promised to sign an order for it to become a policy from September in all schools of Cameroon. So basically what we are saying is we need to start early, we need to start to target adolescents. Adolescents are found in school. We need to not only to act on knowledge, but also to environmental enablers, and we need to co-construct to be sure of ownership and sustainability. And we've had the proof of concept that way produces results above our expectations. That's what I would say for this question that you asked.
Thank you so much. I really like the way that you've supported the agency of the children themselves, the adolescents themselves, actually driving policy change. That's beautiful. Talking about policy change, Professor Barquera, you've been through some exciting journeys in Mexico, but considering the growing evidence of the impact of sugar-sweetened beverage consumption on childhood obesity and diabetes, what do you believe are the most effective public policies to reduce their consumption among children and adolescents?
Thank you, Sean, and a pleasure and an honor to be here with you and with the other guests online. And I think it's impressive what we achieved with the soda tax in 2014. We were not expecting this. We are a country of 130 million inhabitants with a very high consumption of soda. So even though the soda tax was relatively low, it was below what is recommended by WHO, that is around 20%. It was only 10%, but the reduction was almost like 7 liters per year per capita. So this is representing more than 200,000 tons in a year. So, and this was immediate. This was not related to behavior or to convincing or educating. It was just like automatic. After a tax, 200,000 tons of sugar were not consumed. So I think It was a great policy. It's inexpensive to implement. Obviously, it's very difficult because there is a lot of opposition. And later, what we implemented was the warning labels. In the warning labels in all this junk food that say excess sugars and also excess in calories. And this reduced consumption in about 20% of sugary products in the country. Not only that, but also industry do not want to have this punishment of the warning labels, so they reformulated their products. And the reformulation of food industry by itself, on average, was a reduction of 7 grams of sugar per liter across on average in the country. So there was a very important reduction in 2020 in the content of sugar in these products. But we also have warnings for sodium and for saturated fat. So there was also reductions in sodium and fat, and this represented an important reduction through reformulation, but also through decisions of the consumer. And finally, in 2025, a law was approved, a national education law, to ban all these junk foods. So no sugary beverages, no junk food, no ultra-processed products at schools. And this is by law. So now, obviously, the implementation of these laws is not perfect. So we are evaluating that, and we're going to schools, and some schools are still selling these products, but we will be able to evaluate this and to generate accountability and to rank or benchmark schools in the States. And I think this is going to be very important. We are evaluating this. We have 1 year of period to evaluate, but we think we could have health effects. And regarding health effects, and with this I finish, we have seen stabilization of obesity during the last 10 years, no significant increase. So still you see increases, but it's not significant increases during the last 10 years. And triglycerides level on average on adults, a reduction of 15%, and hypertriglyceridemia, a reduction of 17% after implementation of the warning level. So we are starting to see health effects. We are optimistic, but we obviously understand that we need to reinforce, to increase, to try to make more comprehensive policies, and to focus also in communication and education. But we are optimistic on that.
Thanks for sharing that. I think for those of you who may have followed, I think what he said is extremely modest, because I think when you started that journey, probably the Public Health Nutrition Committee thought sugar-sweetened beverage taxes were going to be impossible, and I think you set off a wave across the world. And so we may dig into that more. I think we're going to hear more about the school environment. Han, I really appreciate the Ministry of Education's perspective on how schools in Cambodia are being used as a platform to prevent obesity and diabetes among children and adolescents. If you could share your experiences. I think your microphone is on. Yes.
So thank you so much, and thank you so much for having me here. So it's the first time I'm a little bit nervous, but hopefully I can say. So in Cambodia, through our experience, it's the government putting the human resource as one out of 5 development goals for the country. And to develop the human resource, the first key priority is school health promotion, which is school is the best place where we can implement it, the school health. And our Prime Minister mentioned clearly that pay attention on student health, hygiene, and food safety is the first task, is the first urgent task to take. And as a representative of Cambodian government, the Ministry of Education, Youth and Sport, we have developed policy, strategy, and work plan for school to implement. And in our national school health policy, we mentioned also clearly about the school health promotion and comprehensive school health need to implement in school. And we also issue the guideline prohibited the use, distributing, advertising, and sell all the product and food that harmful to the student in and around the school. And to make this happen, we need to support a lot by working with the inter-ministry. So in Cambodia, Ministry of Education is not working alone for this. We work inter-ministry with joint ministry, 23 ministry, and also 25 province in Cambodia. And this is what Cambodian government want the school to become the platform for prevent the obesity and diabetes. And now the school principal and teacher have also need to promote the key message that less sugar, less salt, and less oil, and 30-minute exercise every day. So we promote this key message in the school, and the student will spread it to the community. Yeah, thank you so much.
Thank you so much. I had the pleasure of visiting the program about a month and a half ago, and what was to me really exciting is that it wasn't demonizing the vendors around the school. It was really working with the school authorities, the local authorities, and the vendors of saying, okay, how do we help you move from these unhealthy choices to healthy choices? And speaking to the vendors, they said they were actually making as much selling healthy options as unhealthy options. So it was really, really quite encouraging. I wanted to have a time check. We're good? Okay, yeah. The bad cop in the back there is going to keep us on time. So second question, starting with you, Professor Eugene. What is the added value of addressing adolescents and pregnant women together as part of a life course approach to nutrition and diabetes prevention?
That's an interesting question, the life course approach. Because the life course approach allows us to see obesity and the risk of diabetes as something that we build across the years and that we have to address with the same perspective. And as I said, with adolescent is a critical period because that's where eating behaviors are being established due to knowledge, due to the influence of peers, due to the influence of environment. And this is really where the habits are being built. And overweight or obese adolescent is a very probable obese adult with diabetes and cardiovascular disease. So it's a real critical period we have to target. And at the same time, we need also to consider that as an adolescent girl is a mother of tomorrow. And if you want to succeed in the prevention, in intergenerational prevention, you must address not only, not think only of pregnant women or mothers. You need to think about adolescents who are parents of tomorrow. That's number one. And at the same time, pregnant women, it's not only now the social and behavioral influence that they have on the community or the family, it's also the biological influence through fetal programming. And it is well known that during pregnancy, eating habits, nutrition status during pregnancy has an influence on fetal programming. That's how the genes are expressed, and they are expressed on the long run and in a transmittable way. That's epigenetics. So during pregnancy, what a woman eats, her feeding habits and physical activity are likely to modify what the biologist will call the methylation of DNA. That's how the DNA will actually translate into proteins and also determine health and disease later in life. So the developmental origins of health and disease. So if in a society you would like to address the obesity and diabetes problem, you need to start from the in utero period. That's addressing nutrition of the mothers during pregnancy. And we've been able, through the same project, to see with a combined intergenerational prevention strategy, we've been able to see things that are actually very surprising in terms of, for example, alcohol consumption, the effect of combined anemia and obesity at the same time, on the risk of maternal diabetes, and also on metabolic changes right from the birth. So in Cameroon, we've decided to address both at the same time. And the interesting thing is that apart from it being driven by NGO and research institutes such as the Institute, it was actually bought by the Ministry of Secondary Education, the Ministry of Health, and of recent, the Prime Minister's Office, who has invited us to say, okay, we are seeing more and more people dying of cardiovascular and cerebrovascular diseases. We are learning that is due to obesity and diabetes and hypertension. What can we do about it? I would say I was shocked by the question that was straightforward. An advisor to the Prime Minister it's 1 week ago, called me and said, we need you to say something about it. What should we do? And I said, we have the answer. We have the answer, and once I come back from WHO, we will put it, yeah. And I talked about this panel that we were planning for. So to make it short, adolescent critical period for behaviors and for biology too, and pregnant women critical period for influence on the society in general, the family, so behaviors of the family, choices of the family, but also critical period for biology in terms of fetal programming and risk of disease later in life. We need to see this as a whole. We need to avoid fragmented approach to health and disease. We need to have this global view, and we need also to know that there are less and less barriers across country in terms of availability of habits, eating habits. The marketing power has crossed the borders, so digital influences is also something that we use much to make sure that we actually succeed in this a broad view of intergenerational prevention. Thank you.
Thank you so much, and you actually read my mind about the next question. Simon, with all due respect, when you started your fight against sugar-sweetened beverage, it was a different world, and now we're in a world where children are increasingly exposed to digital marketing of unhealthy foods and beverages through social media, video games, influencers. What regulatory and public health actions do we consider most urgent in this new universe? And I must say that we only have about 2 minutes left, so about a minute for you, and then Han, I'll come back to you.
Okay, so
it's a brave new world. How do we be brave?
Very quickly, we were monitoring marketing to children in digital areas, like in a very manual way, and we thought we had some measurements of exposure, and we were concerned. There was a meeting at the Obesity Week in the US, the Obesity Society group, and the speaker said, who knows about Twitch? What is Twitch? Raise your hand, and nobody raised their hands. And he was saying, it was an expert, he was saying, this is like 60% of the marketing, digital marketing to children is through Twitch currently. And we were like surprised. Most of the people that was there, we felt we were like more or less experts evaluating the marketing to children, and nobody knew what was Twitch. So I mean, the marketing, digital marketing to children is moving very fast. It's changing platforms. It's changing the way they reach children, and the adults. We are not aware of that, and we really need to put that as a top priority, because This is becoming one of the main strategies of very powerful, politically and economically powerful corporations to still maintain consumption and modify behavior in children. So it's a priority.
Thank you for that. And I want to come back to you. You really described the policy environment, and if you could share more with us of the mechanisms that help your ministry ensure that nutrition and physical activity policies are not just issued, but are really implemented in the school food environment and the daily school life.
Yeah, thank you. So in Cambodia, we have the structure that start from the Ministry of Education, and we have school health structure. So the Ministry of Education is the first one, and then we have a school health office in each province of education, and the school health office of education is working directly with district of school health education, and they work directly with the school principal. And we have also a teacher who is responsible for school health in each school. And we, I'm sorry, I did it again. And we also have the school health committee, which include authority, parent, and school committee, and also include health sector to help together to work on the school health promotion. Because in school we don't have expert on health, so we need to support a lot also from the health education. And now we are implementing one project with Helen Keller under the support of World Diabetes Foundation. So it helps a lot to help the policy, to help the guideline in use, and to see that it's really work. So the project is work to encourage the vendor to sell healthy food and original food from the community. And the project is work with not work only with the school, but with the school parent, that we want them to grow their own vegetable and fruit and to cook for their children. And the project works very well. It's very impressive when you go back to the school of the project, and the school environment is not 100% change, but they change a lot. The school vendor, the school canteen, the food that they are selling, it's changed very much. And especially during the school fair, we see that a lot of parents come to the school and they bring all the vegetable and fruit that they grow in their house. So it kind of encourage the student to eat healthy food, encourage the vendor to eat, to sell healthy food, and also to encourage the parent to grow their own food, not to sell, to buy from the market. Because in Cambodia, some vegetable in the market, it's very, like they use a lot of chemical. And during the reflection meeting with the school principal, they saw very impressive and very interesting with the project. It helped them a lot to manage this food, even though we still have challenge actually. But the project went very well, and hopefully the project will continue and spread and extend to other provinces, because the project only now we are implementing in 6 provinces and 150 schools. But this is very work well, because we work with the authority, we work with the community. We are working together, not only in the school, but all in one. Thank you so much.
Thank you so much for sharing that. May I have a round of applause for the panelists? I think we don't have time for questions from the floor, but we may come back to you. And I think now I'm going to call up Dr. Marc Baron, who's the founder of Forum CCNTS and International Diabetes Federation Blue Circle Voice, and Amber Huet Garcia, board member of the World Obesity Foundation. Welcome, and thank you for joining us. And this part of my job is really easy because my job is just to read out the questions you actually shared with each other and then get out of the way and you're going to have a chat back and forth. So one question, there are two questions. So Mark, you shared a question. Is it possible as a person living with diabetes or obesity to influence decisions that will affect your health? And then Amber, the question you shared, in case you don't remember.
No, never.
What are the top 1 or 2 priorities they should focus on to impact children's health? So I'll leave it over to you two to debate those 2 questions.
So the conversation prior actually kind of changed what I think we should talk about a little bit. But I do want to talk about the top 1 to 2 priorities. I am a lived experience representative on the World Obesity Federation's Board of Trustees. But one of my other hats that I wear is that I'm a school board member in Memphis, Tennessee. It's the 25th largest public school system in the United States. And so the insights I have into health and how much we've talked about schools has made me think about what are the policy things that we've seen in public school systems. Talk about it is compulsory for most students, right? We meet people where they're at. And how are we including youth voice in that? So I had some actual examples of things that are working in at least U.S. public schools and talk about like what are some of those things drawing from our experiences that we could leave here today excited to be advocating for in terms of policy. But before I jump into some of the things I was thinking, I want to hear what your reaction was before.
No, I think it's good that you mentioned schools because some of the points that I want to bring is about schools. So how to advocate to improve the environment in schools to reduce the risk of obesity and type 2 diabetes, obviously in children. I think it's key, and as Dr. Barker has shared, it is so part of the success, the big success of Mexico, but also in Brazil we have some important programs on that. But please, you first. You are the specialist in school. I come next.
Yeah, it's my 4th year on the board, and I go, I wish I would have done this, right? I think it comes to me as the mechanisms we have in place. It actually comes down to resources. Public school systems have a lot of fixed and mandated costs. They have really big budgets. We have a $2 billion budget for just my school system, with about 1.7 of that just for buildings and teachers. So you really have not as much flexibility, and we see governments facing the same thing, right? So one of the things that is working and helping to get nutrition evenly is our community eligibility provision in the U.S. So over 25% of your students meet certain thresholds for low income. They get a free breakfast and lunch. So that's true where I'm at. So it removes the stigma. It actually ends up, it costs less to administer the lunch program. Is how can we use that criteria base at a federal government level and pass down things for one of the big challenges we see is students not participating in athletics because they can't afford the uniforms, or a third-party vendor. If my girl Michelle's watching, my board colleague, cheerleading, which is an active sport, right? Students don't participate because they can't afford it. So can we use some sort of criteria for athletics or involvement in activities that promote movement? So that was just my brain thinking about how do we apply that. How can we do TANF block grants or temporary assistance to needy families, having parameters around that? Community schools, we've started that in Memphis. We have about 6. So we have an elementary school that actually has a grocery store attached. It is stocked by our local food pantry. Students go through it on Fridays. They get backpacks, meals in their backpacks. There's a discreet door. So there's a lot of things that are working in schools, but how do we scale that? And have we asked kids what they think? That's something.
Yeah, thanks. I'm gonna share a little bit about the schools in Brazil, as I said in the beginning. So that are very important to for obesity and diabetes. But before that, I should share that I'm a person living with type 1 diabetes for 35 years and now working with NCDs in general in Brazil and also in collaborating with different international organizations. But in Brazil, we have a program that stimulates for public schools that the foods that go to public schools are foods produced locally by family agriculture, fresh foods and also minimally processed foods. And this, so to have an idea of the scale, goes to 100,000 schools, so it benefits 20 million children in the country. But it's important also to say that it's in public schools. In private schools, we see that in private schools, still ultra-processed food is offered to children, and this is where we come to if we should participate, if we can participate, and the answer is yes. Civil society has been advocating for changing this, and now several projects of law have been adopted in different municipalities and states to stop selling and providing ultra-processed food in private schools as well. So yeah, this is one of the examples I would like to share in schools.
Yeah, and then, I mean, thinking about other policies that we've implemented, we talk about it in a restrictive sense or a punishment or a taxation. It sometimes has a negative connotation from the start, like, or a reaction, and you're limiting my rights, right? So I think there's this building of mindset around potential unintended positive consequences, and getting like local decision makers to say we're just gonna try this and see what happens. I think an example of this, we banned cell phones in the district, and there was a lot of panic over what that would mean. And we saw things like when we had, lockdowns, suddenly there wasn't a panic from students to parents or student to student, and we go, oh, we didn't even think about that. Like, students are actually just far less stressed. We know what social media is doing, right? But it actually, our kids felt safer. Teachers were like, I have their attention, right? Teachers loved the policy, right? And we thought we would get a lot of complaints, or there wouldn't be discretion if a high school student needed to call mom to pick up a kid, right? Like, this is, people governed themselves around like a practical policy that improved conditions in a school. So I think we can do that, and also have a flexibility of that we're trying things. We have not meaningfully improved childhood obesity. So taking an approach of, we're going to try new things and work with our local officials to see what can happen when we try this. So.
Yes. No, I totally agree with you. We saw before legislation several private schools trying to remove ultra-processed food and having to revert to the decision because parents asked it to revert and to bring back the ultra-processed foods to school, so it's not easy. And as Dr. Barquer said, it's not easy then to monitor, to make sure that the law is implemented and it's truly happening after the implementation. And something also that I'd like to share is that in Brazil, 1 in 4 of our adolescents have obesity or overweight. So obviously there is concern. And attached to that, I would like to bring up also the question of stigma, which is obviously something that is suffered by individuals living with obesity and diabetes and their families as well. So which limits to look for care and also to participate in decisions that should have their voices in the participation.
Yeah, and I think acknowledging that stigma and bias show up different for students and for young people. Things like bullying policies, including weight or health conditions. I think the education of obesity as a chronic disease is important. So you, in talking about it in health courses, there's this also, and I've heard about, surveillance has been intermittent in certain areas because we give parents options. But I distinctly remember going home with the full school picture on a piece of paper, and our height and weight was underneath it. And I was the only kid who had 3 digits. I was 101 pounds in kindergarten. And my mom was furious. So 2 things happened. One, my weight was never on that paper again. But then my mom's reaction to it also told me that I should have shame associated with my weight. In that public setting, not having peers weigh you, but collecting that information, because when we have comprehensive information, then we can have comprehensive solutions. We have 43% of the children in the district that I'm on the school board for have obesity. Diabetes is actually the 3rd highest chronic condition for nurse visits. So nurse, and I know we don't have a lot more time, but I think nursing, meeting students where they're at, we have a 1 to 750 student ratio for nurses, thinking about that investment early, and what do students need? Ask them the question, what do you need to feel healthy in your school building, in your day-to-day life, and making that education that we get here a vital component of what children are learning.
Yeah. Yeah, so I'd like to share just 2 more points here of our advances in Brazil regarding reduction of risk for obesity and type 2 diabetes in children, but in all the population. So one of them is front labeling, that we start to have front labeling since 2022. And more recently, a tax reform that was so important that now is being discussed. Obviously, what will be the tax, but anyway, it is already approved for sugary drinks, tobacco, and alcoholic drinks. But also, I think there is an additional point that is very important. There is the reduction of taxes and the removal, including of taxes, in healthy food in Brazil. So I think this was an important move, and this the participation of civil society, the pressure from civil society was instrumental to be able to achieve this, and also to bring the evidence to decision makers to go ahead with those plans to move ahead on these policies.
I don't know if we gave 1 to 2 points. I think what it sounds like is using the mechanisms we have in place for things that we know work. And schools seem to be the headline here. We have the power to get resources to children. It is a political will at this point. We know when you invest in people, the younger they are, the longer your health is over your life. And so how do we get children as advocates for themselves and in those systems that already exist? So I think if we could leave here thinking about the young people that we know and the levers that we can pull, we can make a lot of change immediately while global or your national systems catch up.
Thank you so much for sharing these reflections with us. I think it really grounds us in that reality that's so important. We now have our second panel, some global experts. Peter Schwartz, I'll call you up. Sanna Frost-Helt, call you up. And Emma Zweibler. I think I've been given instructions that we might shorten this panel a little bit to allow for more networking time out there. So that's the bad cop who made that call. It's not the good cop here, right? Beatrice? Okay, good. We just want to be clear about roles here when we do the final evaluation. Peter, I'm going to start off with you with your first question. We might not get to your second question. With diabetes cases projected to rise sharply in the coming decades. How can integrating childhood obesity prevention into national diabetes strategies help shift the trajectory, particularly in low and middle income countries?
We have to recognize that it is a problem. And that's why the panel we just had here was so important, discussing the different pathomechanisms, social determinants, the life course determinants. And if we accept that this exists, the next step is to think about what are the right actions to go ahead. I'm president of IDF. We see diabetes is rising so fast, and the numbers actually are probably higher than we think. But what is the fastest growing group in this? These are children with obesity, children having type 2 diabetes at an early stage. And we have to hold this. If I talk as a scientist, I would say, okay, if we have to understand the pathomechanism why this happens, and we ultra-processed food and fried carbs and artificial sweetener, all of them, they have components into it. But what are they doing? They lead to an early accumulation of fat in the liver. I apologize if it's too pathomechanistic, but if we really want to prevent something, we have to prevent early fatty liver disease. And now we have a target. Yeah, and now we have to think about what can we do to tackle this. And of course, the best is to prevent it from developing. But every one of us has fatty liver disease. There's no doubt about this. And if we are able to develop healthy lifestyle interventions, like we have had the examples in the schools, yeah, then we might reduce liver fat, we might abolish liver fat, and this is the biggest gain of health. So we have to combine policy, we have to combine pathomechanistic understanding, we have to translate this into actions, and the examples we had with sugar tax is brilliant. But we might even think about a liability of food industry for adverse health effects of the food products they sell. Yeah, we have it for drugs. Yeah, you have the long paper listing all the side effects of the drug if you are eating it. And if you eat a drug and some people die, yeah, you have to take it off the market. Thinking about a similar model for food industry, yeah, it immediately, like you have said about the sugar tax, it immediately could change the attitude of the industry. Because if we are honest, the industry knows much, much better than we know what are the adverse health effects for the food products they are selling. So thinking about where it's coming from, thinking about society and policy, going into schools, healthy nutrition education, healthy lifestyle education at schools, thinking about policies, building in healthy environments. We discussed it up front. Physical activity, we were a little bit disagree about this point, but building an environment, what makes physical activity necessary for living in this environment could be a big step ahead. And I think we know what is needed, we know what policy is needed, we know what stakeholder we should bring into one boat, we have to act. And this is where we need politics and a political environment. And this is why it's so important to discuss it here. So thank you very much for the invitation. Thank you for all the discussion. And thank you for the commitment in this group. Let's build a community of those who are committed and passionate to fight against childhood obesity.
Thank you so much for that. And on that policy front, I think one thing I'm taking away very much is that the huge advantage we have children who can actually be voices of change, because politicians listen to many influences, and as you said, a lot of the food industry is going to fight against some of these policy changes if there's not active citizen engagement. Sana, from the World Diabetes Foundation's years of experience working in low and middle income countries, what practical systems and community level investments are most critical to turn childhood obesity prevention from high level commitment into everyday practice for schools, families, and primary care?
So thank you so much. And I think so much has been said already by this amazing panel that we had, and then the conversation that we just heard. So many of the points that I actually really wanted to bring out have been so eloquently covered already. So, you know, this whole thing about that it requires a systemic approach. That drop-wise action here, but not action here, multisectoral approach, that is needed. And I think that's a term that we use a lot. We talk about multisectoral action. It's far easier said than done. It's something that we can all nod to and say, yes, this is what is needed. But actually implementing it is so difficult. And one thing is agreeing up here at this level. Another thing is translating that down to community level, to district level, where you again need that multisectoral action. You need it within the school environment, you need it within the health environment, etc. But if I could stress that, and that would be an interesting conversation, because we can talk about the school settings and the health settings, etc., and the food systems, but all of that needs to come together. So that, I think, is one thing that I wanted to maybe add in at this point. I do hope we get to the second question as well. The other thing that I find may not have been talked about so much is really about you could say the community level, the creating the demand, because we can make all these systemic changes and policy changes, etc. But it really needs to be taken up by the community. The community, whether it's children, parents, whatever, they need to buy into it. And I think it's really important to factor in and address social and cultural norms and social determinants. And I like to be anecdotal, so I go back to maybe one of my first visits to Cameroon many years ago, and I would be delighted if this has changed since then. But I recall already at that time, and we're going 20 years back in time, where we talked about obesity, and already at that point there was quite a high level of overweight and obesity amongst, we were looking at women at that point in Cameroon. And I was being told that the cultural norm was such that when you get married, the husband has to gain weight within the first year. If not, then the wife is not a good cook and she's not a good wife. And the wife has to gain weight within the first year, because otherwise the husband is not sufficiently supplying or catering for the woman. That's a cultural behavior that needs to be addressed if we want to do something about obesity, because that of course also carries into then what is the nutrition in the family, what are the children exposed to, etc. And I think that is something that it's difficult, and something that we don't necessarily take as much into consideration when we're talking about the policy change.
Thank you for that. And doing that in a way that doesn't lead to stigmatization, right?
Yeah.
Which makes it even more challenging. Emma, you come from a very different perspective from many people here in the room, as the CEO of the World Federation of Sporting Goods Industries. And so what is the sporting goods industry's commitment to supporting childhood obesity prevention in line with the political declaration of the 4th UN high-level meeting on NCDs and the WHO guidance? You saw that question ahead of time.
I forgot the question.
So I'm glad I repeated it for you.
No, thanks, Sean. And you're right. You said at the start that you feel a little bit out of your depth. I feel a little bit like a fish out of water, because I'm definitely not going to talk about food or sugar or taxes. But I do want to take time to talk about something that should be very natural and normal for children and youth, which is play and movement. And how do we reintegrate that back into their childhoods? And I'm representing the sporting goods industry. That's the organization I work for. And what we want to explore as part of today, and to talk about in terms of the political declaration, is how can we use what's already core to our industry, which is helping participation in sport, grassroots sport, physical activity and movement, to actually try and make a change to the critical topic that we're talking about today, which is, of course, childhood obesity. And I mean, in terms of the political declaration last year, we were very pleased to see physical activity represented within it. But I think if we're candid with ourselves, it probably only reflected what we all already collectively knew, right? That physical inactivity is one of the main risk factors for childhood obesity, and that physical activity itself is one of our policy best buys in terms of cost-effective, high-impact interventions. The problem arises, and it's a familiar problem, as we move from the declaration to actually implementation. because physical activity, and that's what we've learned over the last couple of years, working much closer with our colleagues at the WHO, is that it's quite often the overlooked, under-leveraged, underfunded intervention. And this is the challenge that we face now as we move from last year into implementation. And just so we're all on the same page, because I've learned a lot sitting here today about food, sugar, and taxes, but I spend my life talking about physical inactivity. So, I mean, when we look at the next generation, 81% of the next generation are physically inactive. And it's not a high barrier. It's 60 minutes of moderate exercise per day. And, you know, I represent the sporting goods industry. It's really important to say we're not talking about competitive or elite sports. We're just talking about natural movement. And when we try to move on from that, we have to find different ways to tackle it. Because a lot of what's happened, we've talked about today, and there's been amazing interventions, I agree with you, is talking about, okay, we're still here, how do we move forwards now? And one thing we've reflected on in the sporting goods industry is, you know, we see these declines. We call them falling participation rates in sports. That's what we call them in our world. And it's not enough for us to talk about that in the sports ecosystem. We have to bring our knowledge, our experience of what has worked well within the sports movement to the health community, and to understand how can we work better together, because there is a common alignment there in terms of we all want kids to get back to that play-based childhood where they have these healthy physical activity moments. So over the last couple of years, and in terms of what we are doing to try to help implement the political declaration, we spent a lot of time with our colleagues at WHO, who I think are in the room here, working together on an MOU solely focused on physical activity. And we've now managed to, I think I can say, upgrade it to official relations status. We will continue to be solely focused on how can we improve physical and mental health through grassroots sports and physical activity. And we are also making sure that we are bringing our industry with us. This time last year, we published our industry's first ever impact report, talking about what we are already doing as an industry, as a sector, in terms of product innovation, community interventions, research and development, and workplace interventions. But probably what's most important for this room is that we said much more needs to be done. It's not enough just to say, okay, this is what we are doing today. We need to do more. We need to bring more of our industry with us, and we need to find better ways to work together. So I will finish, because I know my bad cop at the back not here. You know, and you'll forgive the sports pun, but somebody has to bring it. Like, in terms of what we are doing with the political declaration, let's say our away game is we want to keep showing up within our health community and understanding how can we better work together in terms of partnership on physical activity, on sport, and on movement, and to try to make 1 + 1 make at least 3. I think we've seen over the last couple of years we haven't yet managed to even sometimes make it 2. There's far too many siloed efforts. And then from our home game, we have a real responsibility as a federation and as an industry to continue to invest in initiatives and interventions and in product. There was a great comment around school PE kit earlier about how can we make changes to the products that we create that actually makes sport more affordable, more accessible, and more inclusive for all. And there's been some great examples of that recently. The challenge remains it's all still too siloed, and that's why we're here today, and that's what we'd like to take forwards.
Well, thank you. Thank you for sharing that. Beatrice, time check. Can I go for the second round of questions? But we'll ask that people be very quick in their responses.
I'm not prepared for a second question.
So, Peter, do you want to skip your second question?
No, of course
no,
not.
of course not. So the World Diabetes Day 2026-2027 theme focuses on early diagnosis and prevention. How can this theme be leveraged to drive stronger policy action and investment in early life interventions, including childhood obesity prevention?
I want to be disruptive
Good,
and add
go
something
ahead.
what Sana has said about the examples. I was 2 weeks ago in Nairobi and discussing about obesity and another stigma in this field. And the people told me, no, don't talk about obesity. I said, yeah, why? We are here talking about health. No, obesity means you are HIV negative. So it's very positively perceived, because if you are slim, the people believe you are HIV positive. And I must say, I totally didn't have this on the screen. So this is something we often don't understand the environment. We have to understand it. Second, I would like to add to you, only walking 600 meters, it means 1,000 steps more than you normally walk. has the same glucose lowering effect, then you have a double daily doses of metformin, the standard therapeutic for people living with diabetes. So true diabetology or prevention is not in our brain as diabetologists, not in our prescription, it's in the muscle of our patients. If you could activate these muscles, but we are often not able to activate our own muscles, so we are not a good example. 23 hours and 40 minutes, we are physical inactive per day. It's a disaster. But your question was about World Diabetes Day, and it's called Early Diagnosis and Prevention. And what I would like to motivate you, if we are thinking about early diagnosis, let's translate this into prevention, because early diagnosis, we could argue, is already too late, because we are not able to, or we were not able to have enough physical activity. We have obese children. So early diagnosis is too late. Let's translate this in prevention, 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 because this is what is needed. And an organization like IDF, together with World Obesity Federation, together with WDF, and the World Federation of Sports Goods Industry, stand for it to make everything possible, achievable, accessible, and available for more physical activity, less obesity, and more health for children and adolescents. Thank you very much.
Thank you. Sana, your second question is, how does a prevention first, so it links very well, upstream approach focused on early life course stages help countries reduce the future burden of type 2 diabetes before clinical cases emerge?
So thank you so much, and thank you for allowing us time to go into the second question. So here I would actually really like to talk about using pregnancy as a really crucial window of opportunity, and Dr. Eugene alluded to it in his remarks. So when you look at pregnancy as a window or as an entry point that can, in my view, or our view at the World Diabetes Foundation, be used much more intentionally in unlocking so much more health, preventing future obesity, preventing future diabetes. So pre-pregnancy, we have, as Eugene also spoke to, the in utero programming, pre-pregnancy counseling around healthy nutrition, healthy lifestyle, exercise, etc., can really be used as an entry point. It doesn't have to be in the health setting. It can be, in our case, we support in Bangladesh. It's very much through religious settings where we have this kind of outreach to pre-marriage counseling with couples. It's also during pregnancy, during antenatal visits. Women come in for these antenatal visits. It's one of the times in life where you most frequently and regularly come in and actually attend health settings. And there you can address both, as we talked about, the overnutrition, the undernutrition aspect. And undernutrition also fuels the obesity, as we know. So a woman who's undernourished during pregnancy, so the fetus is undernourished during pregnancy, and even just normal food levels when you then enter the world, it becomes too much. So we're programming at that point. And also it's generally a time when you're really receptive to messaging that's carried into your life, to the life that you carry in you, to your family, etc. When we then move into the postpartum side, again, you can continue the same kind of counseling. Breastfeeding now also comes into the conversation. And then you move the child into the child health and immunization setting. All these windows, I think, can be used. When we look at, that's an area we work a lot in from the World Diabetes Foundation side, is on gestational diabetes, and really not just to have healthy pregnancies and healthy deliveries and healthy mothers, healthy babies, but really looking at also, is there something around that there was a gestational diabetes that impacts both the mother and impacts the child, where again we can work to prevent onset of diabetes, perhaps entirely, or at least delay it. So I would say using that much more intentionally, I think we could actually make a dent on on prevention.
Thank you so much for those remarks. Emma, your second question is, I think, building on your first remarks, what policy changes and actions are needed from governments to enable and empower young people to be more engaged in regular physical activity?
Yeah, thanks. And maybe I would just like to add something to what Sana said, because I have the luxury to live in Germany, where the healthcare system is brilliant. But I've just come back from my second pregnancy. I had my second daughter in November, and not once did anyone ask me about my physical activity levels. Not once did anyone encourage me to go for a walk or to stay fit and strong and to do some kind of weight-bearing exercise. So, not to sound like a broken record, I did give you the disclaimer I was only going to talk about sport and physical activity, but it is a good example. You know, if I didn't have that inherent knowledge, I wouldn't have known to do it. And when you feel physically tired like you do in pregnancy, it can be difficult to continue. But in terms of the actual question, I mean, we don't want to reinvent the wheel. There is an existing very comprehensive global action plan on physical activity, GAPA for short, that was launched back in 2018 to 2030. The biggest challenge with it is that the policy actions are not being met. I think the author of the Global Status Report 2022 is staring me in the face, so I'm probably going to misquote it, but the progress that was evaluated in 22 in terms of how implementation was getting on at the national level was slow and uneven, which I take to be very diplomatic WHO speak to say it's not going very fast or very well. And I think, you know, those policy recommendations are still valid today. We live in a different world, right? I think we talked earlier, or you talked earlier about, you know, the transformation towards digital marketing being a challenge. We live in a world of wars, geopolitics, and even more strained health systems post-COVID. The Global Action Plan on Physical Activity is still valid. The policy recommendations in there are still good, and especially we've talked a lot today or this evening about the importance of early intervention, and there is a lot of recommendations in there about how we can support children to get that early positive experience of physical activity and movement, because we know that's so critical to leading long, active, healthy lives. And you're right, it does build on my first comments, because we have examples within our industry where companies are going out and investing in evidence-based coaching initiatives, or reforming the PE kit that's being done, being worn by particularly girls at schools. But wouldn't it be great if those could be done in partnership? Wouldn't it be great if that could be scaled up as an example of how we can best work public and private sector together? Because I believe the intention is there from both parties to get the same outcome, but we're still too siloed and the pace of progress is too slow.
Thank you. Could we have all of our panelists stand up and give them all a round of applause? Thank you. You can take your seats. My job now is to close this. Now, I think that my instructions were try to actually make some summary remarks. I'm not even going to, but maybe I could try, but I probably would miss the boat. I guess I will go back to my confession up front of how I felt out of my depth. So I found this incredibly enriching. Thank you for that. It's always fun as a moderator to feel you're stretched. But I also feel very reconciled that we're not at all fighting against undernutrition and micronutrient deficiencies and fighting against overweight and obesity. It comes together in the first 1,000 days where we've neglected so much the mom and the first 9 months of those first 1,000 days. It comes together in the need for structural approaches so that, yes, behavior change is incredibly important, but we need to create enabling environments which favor positive behaviors, don't make them almost impossible. And we need to look the problem in its face, understand what it is, apply what we know works at scale with urgency, and be open to continue to learn, because we don't know all the solutions, but we know enough to act on while we continue to learn and update what we're doing. And that all of this requires most fundamentally political will. And I think this, again, is an issue where, as in so much of public health, how do you bring that groundswell of support from communities themselves, demanding the policy changes, demanding the quality services, because top-down policies might be a start, but there'll always be a backlash if there's not the buy-in from the communities we serve. So thank you very much, everyone.